Hello, everyone. Thanks for joining today's webinar. We're simulcasting today, so I'll give it a few seconds while we set up on Facebook Live before we get everything started. All right. Good afternoon, everyone. My name is Ryan Woolley, and I'm the Director of Public Education here at the American Kidney Fund. Thanks for joining Anemia Chat, Managing Anemia of CKD. Today, we're looking forward to continuing the conversation on anemia of CKD. Even though having anemia doesn't always mean you have kidney disease, anemia is a common complication of CKD. More than 37 million American adults may have CKD, and it is estimated that more than 1 out of every 7 people with kidney disease have anemia. Anemia is actually most common in people with stages 3, 4, and 5 kidney disease. We'll be spending the next half hour talking about how anemia can further impact your health and well-being if you're living with kidney disease. We'll also talk about how different treatment options can help. And a special thank you to our guest for today, who is here to help answer your questions. Dr. Gates Colbert is an assistant clinical professor of medicine at Texas A&M College of Medicine in Dallas, Texas. He is also the program co-director for the Nephrology Fellowship at Baylor University Medical Center. And he received his nephrology training at UT Southwestern Medical Center in Dallas, Texas. Welcome, Dr. Colbert.
Yes, thank you, Ryan, and good afternoon to all of our attendees. It's great to be here with you today.
We're so happy to have you. And before we get into questions, let's go through some housekeeping. So as a reminder, this event is being live streamed on Zoom webinar and Facebook Live. If you're watching live, we encourage you to join the conversation. Let us know you're here in the comments section, and please type any questions you have using the Q&A feature on Zoom or the comments section of Facebook. And we'll try to get as many of your questions answered during this Q&A section. In the meantime, we'll start with some questions that were sent in from people who registered in advance. So in our last anemia chat, we talked about what anemia is. And for anyone who may need a refresher, Dr. Colbert, could you give us a clinical definition for what it means to have anemia of CKD?
Sure. So anemia is really a measurement and a clinical diagnosis of not having enough red blood cells or hemoglobin to carry oxygen to your tissues to function normally. You know, we need oxygen in every single one of our organs in the body, and we need an optimal amount of oxygen to do all of our daily functions, for our brain to work, our muscles to work, and all of our organs to do what they're supposed to do to live normal and healthy lives. But some people don't have enough oxygen being delivered because they're anemic. And so we measure anemia usually principally by looking at their hemoglobin levels. And a hemoglobin level is a measurement of how much carrying capacity of oxygen you have with red blood cell delivery. And so a normal hemoglobin for a woman is going to be between 13 and 15. And with men, it's usually between 15 and 17. There is some slight variation. And women naturally have a lower hemoglobin than men for 2 reasons. Number one, if they're in the menstruating age, it's normal process of having blood loss on a regular schedule that men do not have. And then additionally, testosterone hormone produces and accelerates hemoglobin and red blood cell production. So the more testosterone you have, the higher your hemoglobin may be. So we're trying to look, when we're looking at our CBCs and our blood counts that our patients are getting, we want to look for that range for each of our patients.
Great, thank you for that overview. So do you know why anemia is such a common complication of CKD?
Sure. Yeah, unfortunately, anemia is a big problem that patients with CKD face. And there's a multitude of issues that come up that cause this anemia to occur. And up to 50% of our CKD patients have anemia, and it gets worse as your CKD stage gets higher or your GFR falls. And so there's a lot of different aspects that play into that. So an obvious one that many people may recognize is patients with CKD have a lot of blood draws. We have to measure how your electrolytes and your kidney function are doing by a blood draw. So it's normal to have blood draws on a monthly or quarterly basis, or even more often, depending on your current medical problem. Additionally, patients with CKD have a high inflammatory condition in their body that's part of just having chronic kidney disease. And so that inflammatory state causes a sequela of multiple problems. So number one, it decreases your red blood cell life. Most normal people have a red blood cell life that's up to 120 days, but patients with CKD, their red blood cells die off sooner and faster, unfortunately. Additionally, patients have higher hepcidin levels, which is a hormone that's kind of a gatekeeper in our gut that's produced in the liver. Hepcidin is kind of like an on-off of how much iron our body should absorb. And normally when we take in too much oral iron, the hepcidin level goes up and prevents us from becoming overloaded with iron. But when you have an inflammatory state, such as CKD, that hepcidin hormone is turned on almost all the time. And so that causes a decrease of oral iron that you take in by mouth that you would normally absorb in your GI system. It's not being absorbed the way it's supposed to. And so the iron levels in our patients with CKD's body or their bodies is not what it should be, because they can't absorb that iron that they take in through the GI tract. Additionally, that hepcidin causes more problems of preventing normal red blood cell creation and hemoglobin process from happening. Additionally, patients with CKD, and this is especially for later stage CKD and patients who require dialysis, they have lower productions of a hormone called erythropoietin. And erythropoietin is also a normal hormone that the kidney makes that helps promote red blood cell generation in the bone marrow with the use of iron and other different parts of our blood system to create normal hemoglobin levels. And when your kidney starts to deteriorate and not function at optimal capacity over time, your EPO levels, which stands for erythropoietin, your EPO levels go down. And so that process is another step that's going to harm CKD patients from creating the optimal hemoglobin levels that they would need. Additionally, something that has a minor impact but can be a big problem is our diet in patients with CKD. A lot of patients who have advanced CKD are on a more restricted diet, so they may not be taking in foods that have iron in them as readily as they used to. Additionally, some people, their taste changes or their appetite changes, and so that can impair their nutrition. So their normal oral iron intake from foods or supplements can go down as well.
Great. Thank you for that overview for our listeners. And while questions continue to come in via our chat, I'll get started with some questions that people sent to our inbox when they registered.
Sure.
All right, so the first question, how often do you see anemia in your CKD patients?
So we see it pretty often, but you have to be on the lookout for it as a physician and clinician. You know, it's very rare that a patient's going to come into their doctor office or their clinic visit and say, "Doc, I feel anemic today." Usually it's beneath the surface. The hemoglobin levels can drop and you can have no symptoms at all. You may be well compensated and don't think that you recognize any changes, but some people do recognize a lot of changes. And common symptoms that happen with anemia are decreased energy or fatigue. There's a lot of changes in sleep. You can either be falling asleep everywhere or maybe you can't stay asleep. And also a lot of people who have anemia and have changes in their sleep have restless leg syndromes. They may have pins and needles or creepy crawlies on their legs or on their arms and hands that's new and changed. They also may get short of breath or not be able to do the same sort of stamina or exercise that they used to. You know, maybe they can't go on as far a walk as they used to. Maybe going upstairs has changed and now they get more winded when they get up to that second story. And a lot of these things can lead to depression as well. You know, a lot of these symptoms change your lifestyle and that can lead to depression and anxiety about your health and how your body's changing. And, you know, we have to pull these symptoms out of patients because patients may not recognize that this could be related to their kidneys. They may think, well, I'm not sleeping well. This is something I need to talk to my primary doctor about or see a sleep specialist, but it could be related to anemia. So they may not even bring it up in a CKD clinic or hypertension clinic with their nephrologist or clinician. So it's something that we need to be talking with our patients, what's changing in their lives, how are they feeling, anything that's new since the last visit that they want to talk about, because all those things are important. And all those different symptoms that I described, unfortunately, there's a lot of things that can cause them. It may not just be anemia. It could be a lot of different life factors, medical conditions that lead to them. So that can also make it a little bit murky. But clinicians need to be very vigilant about monitoring that hemoglobin hematocrit level, and then looking at our iron studies if we see that a patient has a hemoglobin that's not in their optimal range. And so we do this by checking a CBC count. With pretty standard, almost every nephrology visit, you likely would have a CBC drawn with your kidney function labs. And it's definitely checked when you have your annual physical with your primary care physician or clinic, that they're checking your CBC as well to look at that hemoglobin and hematocrit level to see if anemia is an issue for each patient.
Great. Thank you for that. And it looks like some people might have joined us a little late on Facebook. So I just wanted to, for those of you who are just joining, thank you for being here. This is the Anemia Chat, Managing Anemia of CKD. And we have our guest expert here, Dr. Gates Colbert, who is an assistant clinical professor of medicine at Texas A&M College of Medicine in Dallas, Texas. He's here answering our questions today. All right, so moving on to the next question that was submitted. Does having anemia put your health at risk?
Yes, absolutely. And it's definitely a graded scale where the lower your hemoglobin goes, the higher your risk factors are starting to add up. And so just a reminder, women should have a hemoglobin around 13 and then around 15. And as it goes lower and lower, moving towards a hemoglobin of 7, that's when your symptoms are going to potentially worsen or become more noticeable. And the worst case scenario would be that once you get to a hemoglobin of 7, it's usually recognized in the medical community that you need a blood transfusion. There's not a lot of supplements or diet or medications that we can give quickly to make that hemoglobin rise up fast. So it's generally recommended when your hemoglobin gets below 6 or 7 that we need to send you to the hospital and do a blood transfusion. It's very rare to be able to get a blood transfusion any other location. So a lot of times we have to send our patients to the ER. They get a blood transfusion or 2 or 3, depending on the situation. And then they could go home if everything is stabilized. But as your hemoglobin is dropping over time, you're going to have some of those symptoms that I mentioned, fatigue, shortness of breath, decrease in sleep quality. So likely that may change your exercise level, may change your activity level, which is going to lead to other secondary metabolic problems over time. It's definitely going to change how your diet the diet that you may have as your taste is changing as well. It can lead to mental changes such as depression or anxiety about all these things that are starting to add up and kind of seem to be out of nowhere, that you can't really put all the pieces together about why your body's changing this way. And then, long term, these have major impacts of decreased oxygen delivery to our organs, which is a big problem for allowing them to functionally do what they're supposed to do. It can cause changes in the heart, left ventricular hypertrophy, and that's not good because that's something that may be a permanent problem over time. And then, the ultimate problem is it can increase your risk of death in some patients over the long term.
Thank you for that overview. So you mentioned the piece about needing a blood transfusion if your levels get super low. How is anemia generally treated, and what are the options for treatment?
Sure. Yeah, that's a great question. And I would like to first maybe start with to the diagnosis of anemia. What do we need to look at first? So as I mentioned, the most common cause of anemia is usually in women is going to be menstruation or having their normal periods. So you want to ask women if they're in a menstruating age, has their periods changed? Are they more frequent, more heavier? That could be a leading cause of anemia. The second could be some sort of GI bleeding. A lot of times patients don't know because they don't have any pain. They may not notice any blood in their stool, but any sort of a bleeding polyp or malignancy or tumor in the GI tract can cause anemia and slow blood loss. And that's commonly something that patients don't know. And that's why getting your screening colonoscopy as we get 50 and above is very important. And then kind of the next level of common causes of anemia are what I see is going to be patients that have inflammatory states. So that could be malignancy, some sort of change in their autoimmune system, or chronic conditions like chronic kidney disease and heart failure. And so if you have chronic kidney disease, we want to start looking at your hemoglobin levels closely and then start looking at our iron levels. So in CKD patients, it's very, very common that once we see their hemoglobin level is low, below their target range, we want to look at their iron studies, because iron is one of the key pillars of creating hemoglobin and red blood cells. So we want to look at their iron status. We look at how much iron is in your body through a measurement called ferritin. And then we measure how much iron is available for usage, something called a TSAT or an iron saturation, ISAT, depending on what your lab reports. We want to look at those two main variables to see, is your iron level low, or is the iron that you have in your body not working well? So common ways that we would try to improve the iron status, first would be through diet, see what your patient's eating. Common things that we might eat that have a lot of iron in them are leafy greens, definitely red meat, and other, if you like organ meat like liver. Not everyone likes liver, but there are some people that like the delicacy. And then nuts have a lot of iron in them. But our body is designed to not absorb all that iron that's in the food. Generally only about 10% of the iron that we take in by mouth is absorbed. So it's really tough to be able to completely treat your iron deficiency anemia from just diet alone. So then the next step that we might have is we would move to iron supplementation. And there's two ways to get iron into our bodies. We can do oral intake, or we can do an IV infusion. IV infusions are going to deliver a lot more IV iron to the patient. And it's something that we can follow closely. We know that they're getting the appropriate amount in a short amount of time. And it has great data and great results that shows that it's very safe and moves the hemoglobin up at a fairly quick pace. And so there's a lot of options for that on the market right now that your clinicians can prescribe for you. Additionally, you could then either or, depending on how low your hemoglobin is, you could do oral iron. So usually you do oral iron or IV iron. And you, depending on the circumstance of your situation and the comfortable the relationship you have with your clinician or physician, they may choose one or the other depending on what's going on. But oral iron is a good option as well. Usually this is going to be a daily tablet that you're going to take every day or maybe twice a day, depending on the oral preparation. And oral iron, as you take it by mouth and it passes through your GI tract, it can be found over the counter. A lot of people get oral iron tablets at their pharmacy or at their grocery store. A lot of multivitamins have a small amount of elemental iron in them. So that's one way to get some iron replacement. There's also prescription iron supplements that you can take that are by mouth that are effective. But there are some downsides to oral iron that some people experience. It can potentially be associated with nausea, dyspepsia, or constipation in some patients. It can turn your stool black. Not everyone, but that is something that's well known. And so not everyone wants to have that experience. And then, as I mentioned, only about 10% of that oral supplement is going to be absorbed as well in your GI tract. And the biggest culprit is the hormone hepcidin. So hepcidin is the gatekeeper that keeps us from absorbing too much oral iron. But in patients with CKD and inflammatory states, it's almost always turned on. And so your body's fighting against you in terms of being able to absorb all that oral iron you take in. So sometimes that's not going to be the most effective way to get iron into the body. And then once we know that your iron stores are good, either on the blood check initially, we see your iron's great, it's adequately filled up in your tank, or you've supplemented and it's gone up to where it needs to be. Then we may consider, if you have advanced CKD, stage 4, 5, or dialysis patients, they may need to be on hormone replacement. So we talked a little bit earlier about, as you have advanced CKD, your EPO levels, or erythropoietin hormone that's produced in the kidney, goes down over time. And a lot of people who have advanced CKD need replacement of that hormone. And right now, that hormone is usually either a shot or an infusion that you would do maybe once a week, once every 2 weeks. Some people may only need it once a month. But this hormone replaces that EPO that your kidneys no longer produce or are producing at a much lower level than your body needs. So that's another pillar and key component of driving your hemoglobin up to try to treat your anemia as best as possible.
Got it. And we have a really related question while you're talking about the treatment options. Someone asked, do you have to stay on anemia treatments forever?
So the hard answer is it depends. So if you have a temporary problem that has caused you to lose a lot of blood or a lot of iron, if we can fill that back up one time and then you're back to normal, then usually you don't need long-term treatment. But if you have a chronic inflammatory state like CKD patients, and a lot of the patients that I see, they likely are going to need some sort of lifelong treatment. Oral iron intake usually is going to be on an everyday or an every other day basis. One of the benefits of IV iron is you need it much less frequently. Maybe you only need an IV iron supplementation for a few days in a row, and then you wait several months. The big iron preparations that can safely deliver a lot of IV iron at once. Some of those patients may only need treatment once every 6 months. As long as you're not having active blood loss, these IV iron preparations fill up your tank, make your ferritin levels go high so that your body can use that iron, and you may only need an infusion a couple times a year. But unfortunately, with chronic inflammatory states, until that situation changes, such as the best change for CKD is that you either halt your CKD progression, or if it's advanced, you get a kidney transplant. And then that changes everything, because a lot of those conditions go away that prevent hemoglobin production from being hindered. So once you have a kidney transplant, your EPO levels go back up because that transplanted kidney is producing EPO well. Additionally, your inflammatory situation goes down in the body, so your hepcidin level gets back into a normal rhythm. So you're able to absorb that oral iron again. So those are kind of some good change that we would see with transplant.
Got it. Thank you. All right. As a reminder to people who are listening to us live, if you haven't already, please type your questions into the Q&A section on Zoom or on the comment section of Facebook, and keep them coming. We're getting some really great questions coming in. So we have a question. I know you talked a little bit about nutrition earlier, so a related question. I thought that red meat was supposed to be limited in the CKD diet. You talk about kind of your thoughts there and what recommendations for nutrition are.
Sure. So there's a lot out on the internet and a lot of controversy on what should we do about diet specifically related to meat. We know overall that more meat is not better. Less meat is better for CKD patients and really everybody, even healthy people, because red meat contains a lot of fat. It potentially contains acid, and that is detrimental to our body over time. Additionally, red meat may have a lot of phosphorus, and so we don't want our patients with advanced CKD to have a lot of phosphorus intake because they have trouble getting rid of phosphorus. But one good thing about red meat is it does have a good amount of protein in it and a good amount of iron. So I would say that a healthy amount of red meat should be taken in, or other meats, and because that's going to give you some oral supplementation of iron and some protein. Patients who may be vegetarian or vegan, that's not an option for them, and so they would likely need to do a supplementation, and they wouldn't be able to just rely diet alone to treat that. But there's a lot of information about protein intake and meat intake for all kinds of diets. There's definitely been a lot of controversy and a lot of change over time. A lot of people have heard in the past that, CKD patients really need to cut down on protein, not take in too much protein. But we've learned over the time moving into, this year and next year that we don't need to be as restrictive on protein intake as we did previously. So we're allowing patients to take in healthy proteins at higher doses than maybe we have in the past, but it does need to still be in moderation.
Got it. Thank you. And for our listeners, the American Kidney Fund has a great resource. If you have questions on managing your nutrition or you're looking for some kidney-friendly recipes, you can visit Kidney Kitchen, which is kitchen.kidneyfund.org. And I believe the link is being dropped in the chat for you as well. It's a really great resource to find some kidney-friendly recipes. All right. So, Dr. Colbert, what particular, I know you mentioned a little bit about this earlier, but if you could go over the blood testing that's done for anemia, and I know getting a lab result can be pretty overwhelming, and there's different things to be looking for with anemia, and it may not always say iron on the report as well. So could you just give us an overview of what's tested and what a lab report would say?
Sure, absolutely. So I think everybody who has seen a doctor has had a CBC done, and you may not even realize it because your doctor, your clinician may not even mention it if it looked normal, but you've probably had tons of CBCs done over your life. And that's the big kind of report that we're going to initially screen to look for anemia, because that report is going to show us if there's any sort of infection status, what your platelet levels are, and what your hemoglobin and hematocrit levels are. Additionally, it has a whole host of other specific parameters on red blood cells, size, shape, morphology that are not always clinically meaningful if you don't have a true hematologic disease. And so a lot of people have access now to their lab reports early, or they're able to order them, on their own through an online service or on-demand services. And so I spend a lot of time just reminding my patients that the CBC report that you get, it's not a report card where everybody needs an A+ or 100%. Very few patients are going to have every single lab value on that CBC as a normal range. It's normal for each patient to have some sort of variation. And so they're going to have outliers in different settings, especially as they're talking about the different red blood cell morphology and what it looks like. So just because you see something on your CBC report as an outlier, that doesn't mean that you have a problem. I would encourage all patients to ask their doctor or clinician if they're concerned about something or if they want to go over it for more education. But just remember that your CBC report does not need to be an A+ to be healthy and normal. So we're going to look at that hemoglobin level and hematocrit. Hematocrit level is basically just your hemoglobin times 3. It's just another way to report hemoglobin. But we're going to look at that hemoglobin, make sure it's above 13 in a woman and 15 in a man. And then if we see that it's low or potentially it's been moving lower over time, then we're going to check iron studies. Usually this is not part of a standard CBC. It's going to be a level deeper. And so things we're going to order are, we want to look at your total iron stores in your body, which we currently measure by a ferritin level. And our goal would be to have a ferritin level above 100. 100 or higher would be considered normal. If the next thing we would look at is what is your ability to use the iron that you're taking in. And so we use different values. We have a true iron level and something called a TIBC. And we can do a formula, iron over TIBC, that gives us the TSAT, or the iron saturation, or what's called TSAT, it's going to be a transferrin saturation. And so we want to have a TSAT or ISAT above 20%. That's what we found, that if you're above 20%, your iron levels are adequate in terms of intake and availability to be used. So patients with CKD, and these are from our KDIGO guidelines, which are the big guidelines in the nephrology world that say what would be normal and what should we be treating to for optimal health, So we're looking to see if you have anemia, you want your ferritin to be around 100 or potentially higher. That means your iron stores in your body are good. And the TSAT above 20%. And so that would be that your iron levels are at goal. And we need to look at something else besides iron replacement to get your hemoglobin levels up. Now, something that can be a little bit confusing is we have anemia of chronic disease like CKD. So some patients who have CKD, they're anemic, their hemoglobin's low, we'll say it's below 13 in a woman, and their ferritin level could be high. It could be above 100, 200, 300, 400, but their TSAT is below 20%. And we see, and that would be considered abnormal, and you would still need iron. And so some people might ask, well, why, if your ferritin, which is your storage of iron, if that's high, why do we want to give more? And one of the reasons is that ferritin mimics different things, unfortunately. So when you have high inflammation, your ferritin levels go high as well. So a high ferritin level doesn't always represent iron content. It might just represent inflammation. And something that we would see a lot in the last year or two is, since ferritin is a measure of inflammation, a lot of our COVID patients in the hospital, they have really high ferritin levels, maybe 1,000 or higher, where it normally should be around 100. And it's not because COVID gave them a bunch of iron stores, it's because it was a marker of inflammation. So you have to take everything in context, looking at hemoglobin, ferritin, iron saturation. And if you wanted to dive deeper and to be a little more sophisticated, you might look at some other parameters as well. But those are going to be the main things that is suggested by our guidelines to try and determine what our iron stores are.
Got it. Thank you. And for our listeners, the American Kidney Fund has some helpful tips for talking to your healthcare team or your doctor about anemia treatment, as well as the lab results, because as Dr. Colbert has shared, there's a lot of different things to interpret on the lab. So we have got some good tips for you on our website to help you prepare for that doctor's visit. Okay, and we're getting close to the end of our chat here. So please submit any of your last questions into the Q&A section on Zoom or the comment section on Facebook, and we'll try to get all of them answered before we wrap up. All right, so our next question. What happens if I decide to not treat anemia? I know you've talked about some of the serious consequences, but what would happen if someone doesn't treat their anemia?
So if you don't treat your anemia, the first thing is that you're not going to see the improvement of your potential symptoms. So the symptoms that we've discussed earlier, such as fatigue, inability to perform at the usual stamina that you had, you may have increased cold sensitivity, you may have change in sleep or restless leg syndrome. If you're not treating your anemia, those symptoms could continue on. So that's something that really affects your quality of life for patients. And it may be a simple fix of just treating your anemia. And you may start sleeping better, which is a chain reaction of you sleep better, you feel better, your exercise gets better, your strength improves, and your overall outlook on life can dramatically change just by treating the anemia. But then when we look longer term, if we're having low hemoglobins, low iron levels for years and decades, that's when the big detrimental effects start to stack up. And so that's when our organ dysfunction is going to start kicking in, and we're going to have decreased oxygen delivery, which potentially could affect our brain function. It's going to change the way our heart is structured, where the heart actually grows in size. And unfortunately, the heart, once it grows too big in a size that you don't want, it doesn't shrink back down. Once the heart grows and accommodates that change in hemoglobin level over time, it doesn't go back to normal. So that leads to heart failure, potential other conditions like hypertension, and atrial fibrillation, that unfortunately are chronic diseases that we have to manage for our patients. And then the worst scenario would be it's associated with increased mortality. So if your hemoglobin level is low in the chronic setting and it's not treated adequately, those patients have a higher death rate and potentially could die sooner than the normal lifespan they might have otherwise. So it's definitely something that we take seriously, and we both as clinicians and doctors need to be looking at and seeing how can we treat this condition for our patients. But I would also empower and encourage our patients to look at their own health status and look at their lab reports and ask questions for things that don't seem to add up, or get more education if you see something that you think is abnormal. And also talk to your clinician or doctor visit. If you're having symptoms, just throw it out there. Sometimes a little thing, well, I've been feeling differently this last month. You may think that it's not important, but it may be something new and critical that would help us go down the path of looking for something that's just more than just, well, you're just tired because you haven't been sleeping as well, because maybe your life is stressful, or you have a bunch of kids running around like at my house that makes sleep a little bit more difficult sometimes.
Yeah, I like that. I think you as a patient are the most important advocate for your own health. So it's important to recognize any symptoms and speak up about them. So we also have a listener who says, I have been anemic most of my life, and my doctors were never concerned with it. However, since I was diagnosed with CKD less than 1 year ago, it seems to be concerning. Why is that now?
Sure. I can't speak for all clinicians and providers on why they may not have been as concerned about the anemia. But I will tell you that a lot of people, it's kind of been off the radar in terms of if your hemoglobin level was maybe between 10 and 12 and a half, a lot of people in terms of clinicians may not have been as worried about it as they should have. And I would say when you go into a nephrology office or nephrology clinic, anemia is a big part of what we should be looking at for our patients. So we as specialists are going to focus in on that maybe more than other people would have that you have seen previously, because we know that anemia is associated with CKD and we know that we have treatments for it. So all we have to do is look at our lab reports, work it up, talk to our patients about how they're feeling, and then discuss a treatment plan. We have a lot of tools in our belt to improve your iron status, get your hemoglobin level up, and potentially improve the quality of life. So I would say that your nephrology clinic and your nephrologist is definitely looking at this closely. And if you feel like they're not looking at it close enough, ask them, speak up. All of us are busy. And so some things, may not be communicated as, that they're thinking about it or worrying about it. It may just move through the general conversation. So if you don't feel like they're paying attention close enough, ask them about it.
All right, we've got time for maybe one or two more questions. Here's one that's quick. Could you please repeat and spell the name of the hormone that may need to be given that the kidneys don't produce when in stage 4 or 5?
Sure. So the easy thing is EPO, EPO. That's kind of the acronym. The full spelled out word, though, is erythropoietin, which I know is a long word, and it's spelled ERYTHROPOIETIN. Again, ERYTHROPOIETIN, erythropoietin or EPO.
Thank you. All right, and here's our last question. How often should we check iron studies for follow-up? Every 3 months or every 6 months?
So if you don't have a problem with anemia or we've checked your iron stores are normal, our guidelines generally recommend about 6 months. But if you are on anemia treatment with iron supplementation, our guidelines recommend at least every quarter or every 3 months or even sooner, depending on how low your iron levels are. I would take it patient by patient basis. Our goal TSAT is 20%. If a patient's at 19% and they're on some iron replacement, either orally or IV, I might check it once a quarter or, their next clinic visit if that happened to be a little longer. But a patient whose TSAT is really low, 5% or lower, I know that we need to be aggressive. And so I may check that every month. We want to see a response. And a lot of times we're having to make the decision, but with our patient, they may want to start on diet and or oral iron supplementation first to see if they can move their TSAT up and improve their hemoglobin levels. But we know that if it's really low and we're not seeing movement up closer to 20%, we likely then need to move into IV iron supplementation infusion. So in those patients, I would check closer and be a little bit more encouraging that if your TSAT hasn't moved up a lot with oral supplementation, we need to move to IV iron at that point to really get that patient to goal and to improve their clinical symptoms.
Got it. Thank you. All right. And before we wrap things up, Dr. Colbert, do you have any final takeaways that you'd like our listeners to hold on to from today's conversation?
Sure. I'm glad to be here with you guys and be able to talk about this important topic that we see so much in the CKD population. So I would just remind our patients or families and caregivers that are watching that anemia is a common problem. Up to 50% of CKD patients may have anemia or iron deficiency. So I would say that it's something that as your CKD progresses or your GFR falls over time, it's going to increase your risk factors for having anemia. So your doctor, your clinician may be watching that. They may be communicating it to you, or they may not. So if you feel like that your body's changing, you're having new symptoms that you didn't have previously, big things like lack of energy, problems with sleep, fatigue, your diet's changed, definitely bring that up with your clinician. That's something that we would want to know about, and see if it could be related to your anemia or not. And if it's not, we can go down a different pathway or get you to the right clinician that can help work that up appropriately. But I would say that anemia is, while it's a common problem, the good thing is it's very treatable. This is not, something that you need to be extremely distressed about, because we have great tools and medications to treat your anemia. And we can do that. We talked a lot about iron supplementation through oral supplements or IV infusions. If we find that your erythropoietin levels may be low, we may do IV supplementation with that, hormone replacement. And in a worst case scenario, we give you a blood transfusion and your hemoglobin levels are corrected and move up. So we definitely have great options for treating anemia to get our patients back up to safe recommended levels. And so my final thing is just always talk to your clinicians about any questions you have. This is complicated and complex stuff. And as a doctor, I don't expect my patients to know this kind of thing. This is, deep into the, medical science, and it's our goal to both recognize this and treat it, but also to communicate it with you about what we're worried about, what we're thinking about, what we've seen with our experience might be the best plan to get you back to your baseline or back to normal. So definitely, we all, are busy people. Patients are just as busy as their doctors and their other clinicians. So just be encouraged to speak up for your health because you are your best advocate.
Great. Thank you so much for all this incredible advice for our listeners. And thank you also for co-hosting today's Anemia Chat with American Kidney Fund. For our listeners, please make sure to like American Kidney Fund on Facebook and send us your email through kidneyfund.org to stay in the loop for upcoming events and new educational resources that you may find helpful. And finally, thanks to everyone at home for joining in today. If you're on Zoom, we ask that you please complete the survey that pops up when the webinar ends. Your honest feedback will help us make our webinar program the best it can be. Thank you, everyone, and stay well.
Yes, everyone have a great day.